Hello, everyone. Welcome to today's training. It is an honor for me to moderate this webinar on an important topic for all mental health service providers. The UT at Austin Steve Hicks School of Social Work and the National Hispanic and Latino Mental Health Technology Transfer Center is hosting a three-part webinar series addressing our biases when working with the LGBTQ plus community. This is the second part of a three-part webinar series. Today, our speaker will be discussing understanding health disparities among the LGBTQ community. We are celebrating Pride Month. We have this slogan, providing Latinx LGBTQ plus affirming services is a step towards fewer mental health disparities in a community with mental health, many intersectionalities. Our speaker, Jesus Ortega, is the director of the School of Diversity, Equity, and Inclusion at the Dell Medical School at UT Austin. He is originally from Venezuela. Jesus has worked for economic, social, and environmental justice amongst almost all his professional life. Mr. Ortega moved his organizing and advocacy efforts working with marginalized immigrants communities of color from New York to Texas over 15 years ago. He holds a master's degree in social work from UT San Antonio and a master's degree in urban planning from the City University of New York. He's also a graduate of Columbia University School of Business on nonprofit management. Please learn more about Mr. Ortega in our website. Please keep your questions short and to the presenter topic. At the end, and during the presentation, we will have a Q&A and polls in which you can ask questions to our presenter. Let's get started. Please welcome Mr. Jesus Ortega.
Thank you, Christine, and welcome everyone. Good afternoon for some of you, depending where you are. And thank you again for joining us today to continue with these conversations about what is the impact that biases have on the work of us as mental health providers and clinicians to the LGBTQ population. Today, we are going to move and we want to respect all the principles of the of these organizations in which we're trying to look for strengths-based and hopeful, inclusive language, healing and centering trauma responsive. And then I just want to make the disclaimer regarding the presentation today. And, and thank you to Christine and to all the team of the National Hispanic and Latino Mental Health Group, who has actually brought me to do this series today. This is my disclosure conflict of interest, and today we want to go into part 2. Understanding the health disparities among the LGBTQ community. And last week we did, and I don't know if some of you coming from last week, but we actually talk a lot about the impact that implicit bias have on our work. And we're doing this as a result of a series of Pride Month. And we want to concentrate also on what is the impact of the LGBTQ community and the health disparities that they present. So before we start, I just want to have a sense of who is in the room. And our poll will be, and I believe Cindy is sharing that with you right now. How would you describe your experience with the LGBTQ community in general, and about particularly around health disparities? Cindy, if we can end the poll now would be great. And let's share the results. Are you seeing the result right now?
You should be.
Okay. So thank you everyone for responding. And it seems like we have kind of half of the group have some experience about working with the LGBTQ community, and also half of you have little experience about it. Thank you for sharing this with us. And it seems like we have two people here who have extensive experience. And what I want is for all of us to recognize that this is, as I said last week, part of this journey of learning about how do we work with different populations and how do we become culturally congruent in order to do the work. And one of the things that I always teach when, particularly to my students about cultural competency, is that we get competence until we encounter a new set of cultures or a new set of experiences. And thus we open again to become a learner. So, so today our objective is in a way kind of develop our own self-awareness, our biases, values, and beliefs around the LGBTQ population. We also want to learn about the importance of language within the LGBTQ population, and also expand knowledge on the health disparities, so that in part 3, we can come back and talk about what interventions we can do based on what we have learned from part 1 and 2, and how do we can engage in helping particularly Latinx and Hispanic communities who identify within the LGBT community. So one of the things that I want to share, as we did last week, was establish our 4 agreements in how do we come to this space. I definitely like this platform better than last week. And I know that we do have some feedback in a way that it didn't feel somehow engaging, and it was very hard for me because it was the first time I used it. But I think that part of what I want is to sometimes bring the voices of the people who are here in the way that we can actually participate. So the first agreement that I want to use here is to stay engaged for the time that we want to be in. And I mean by this, stay engaged intellectually as well as emotionally, as that provides information for each one of us in order to continue building this awareness that we all want. And I think that experience discomfort, I will invite you to be, to engage with the discomfort individually and personally, as that provides also sources of information in how do we grow in doing this work. And then speak your truth, whatever that is, because that's your experience and that's the place that you're coming from. And even if you decide not to speak, pay attention to the internal dialogue that you are having as we go through this conversation today. And, and one of the things that evidently we have only 1.5 hours, which is, you know, sometimes people think that that's a lot of time, but it can pass like this. And the thing is also to accept non-closure. This is somehow we engage in sometimes for some of us in these conversations for the first time, and there is definitely room to continue growing and engaging on this series of trainings that we are doing. One of the things that I want to also mention today is that we want to do activities that will provide some language. We all adults, we all professionals, but again, if we experience discomfort, be honest about your discomfort. How do you engage with it? And some of the language could be a little bit difficult, I would say like that. So as just one reminder from last week is that we all have biases, and if we have a brain, we are biases. And sometimes this can actually conflict with our unconscious attitudes and behaviors and intentions. And I think that this is something that we need to be constantly paying attention and being intentional about it so that when we're working with the LGBTQ community, that we can make mistakes, and that's going to happen. So how it is that we can actually provide a sense of continual learning and growing so that that doesn't interrupt and create an inclusive environment to take care, particularly of this very vulnerable population. So our second poll today is, what is your SOGI, right? What is your SOGI, as some people call it? By that, I mean your sexual orientation and your gender identity. And of course, this is all anonymous, but we want to share with you this poll just to see who is in the room and how you identify yourself, or how would you describe yourself based on your sexual orientation and your gender identity. And if Cindy can share the poll with you right now, that would be really helpful. And I believe that both questions are on the same poll, so you can go to number 1 first, and then you can scroll it down and fill this second question after you finish. Let's give it a little bit. We have still a few more people who can answer the survey. Somebody's putting in the chat, Angie Torres is saying that she's having a hard time to hear me. Let me know if my volume tend to be low, but I can actually definitely speak a little louder if that helps. So let's end the poll right now, and we can actually see the results. Okay, so we have 83% of the people, 25 out of the 30, of the 30 people who actually answered the poll are female, identify as female, and 17% identify as male. 5 people out of those 30. And then in terms of the second questions, how would you identify based on your sexual orientation? We have 83% are heterosexual. We have 1 person identified homosexual, 2 people as bisexual, 1 people as gay, and 2 people as lesbian. Nobody else about as sexual, pansexual. All right. Well, thank you. Thank you for sharing this, and thank you for your honesty. And as you notice, but one of the things in a way that how we identify in terms of gender and sexual orientation, you can see all the categories that actually I included there. And I did that on purpose because one of the things that when we're working with the LGBTQ community, that it is important to know is language. And recognizing that we can actually see the many ways in how language has evolved within the LGBTQ community. And I know that, as I'm putting here in this screen, right, that here are, and this is actually terms that you can take either from the web, from Googling, the many ways in which people actually identify themselves as. And one of the things that queer theory, and particularly Black queer theory, have challenged is this very binary way of understanding the way that individuals see themselves. So, so this is helpful in a way that it provides how do we learn, and of course today we don't expect that you learn all the terms of how people identify within the LGBTQ community, but at least to start getting familiar with them. And I think that one of the things that I want to share, and I think, Cindy, if we have a little quiz, and it's not that we want to actually, grade it or anything like that, but we want to share this quiz with you. If we can put it on the chat, Cindy, that would be very helpful. And you can, respond to the quiz later, but I think that it would be good for us to actually look at some of the terms that I'm trying to see where I can share mine so that you can see what it is that that we want to share with you. So that we can engage on the terminology. And this is very helpful just for us to start getting familiar with the language. One of the things that we have noticed, particularly in healthcare, is that when people have at least some knowledge about some of the terminologies, that they are very important. One of the things that I have actually also used is what my pronouns are. And I usually attach them to my name. And we have actually built policies right now, particularly within the medical school and with the Steve His School of Social Work, so that people can actually put their pronouns on their name. Because in a way, it gives people the sense that if this is something, or this is a space in which at least recognize that we can have different ways in how we identify ourselves. So that when we learn about everyone who is in the room, and I was going to ask each one of you to put your pronouns next to your name, if you want to, but what it does is it creates, now that we're doing telehealth and we're doing therapy actually via Zoom, right? So that we are actually providing already that space for people in order to engage with us. And we will talk more about that next week, but I think it is important for us to provide the pronouns. Now, one of the things that I have actually in some of the meetings I've been involved with, is that when people ask to put your pronouns, people feel that, and I have this reaction, but why do I have to put my pronouns? Actually, is it very clear that I'm a heterosexual male? And if I put my pronouns, can people actually take me like I'm gay? So, and what I would say is that part of what actually the pronouns actually do to us is that it create this, start in communicating that this is a safe space for people, right? So, and if there is anybody within the space that prefer a pronouns like they and them, so that we can actually refer to they as such, and we don't assume, and that's very important. So again, you have here gender, two spirits, gender identity, gender non-conforming, heterosexism, heterocentrism, non-binary, gender expression, etc. Two spirits, homophobia, intersex, lesbian, etc. And sometimes, either between today and next week, we will retake this next week, and we will give you the answer sheet at the end so that you can have all the answer and check yours. But try to do it by yourself, right? Even before you see the answer key to the quiz. Just again, part of what it is important here for us is to recognize what it is that we need to learn as we move in this work, particularly with the LGBTQ community. So one of the terms that I want to share with us here today is actually the gender fluidity, right? Or non-binary term. And hopefully you know him, but he actually has these experiences of becoming more gender fluid in a way that it provides a more flexible range of gender expression and identity with interests and behaviors that may even change from one day to the other. And I think that non-binary terms, right, means that a person's gender identity doesn't fit into the cultural categories of female or male. And one of the things that for us as clinicians, and we will engage more in that next week, is this idea that particular, millennial generations and next generations are really challenging the way of how we provide services in a way that it is more inclusive, in a way that it doesn't assume that a person already established a gender identity or a sexual orientation even to that. So these are terms that we will all important to get familiar with as we really want to engage working with this population. Another term that it is very important to put you, and I provide some resources at the end to you, is the terms of intersex. This is, the way that people is actually using, and sometimes we do have the LGBTQI, and the intersex groups actually ask for how we can actually engage with the capital E or capital I or lowercase I. And intersex, this is an umbrella term that describes bodies that fall outside the strict male-female binary. There are a lot of ways someone can be intersex, and particularly these terms refer to the people who either because of their genitalia, either because of their chromosomes or their reproductive organs, can actually be in that spectrum. And I think that one of the things that the intersex group has really been fighting for is the medicalization of intersex people and how those decisions are made by parents. And one of the things is that for the benefit of the intersex person, and one of the things that intersex groups are actually currently fighting is that there is nothing wrong with that. And biologically, there is nothing wrong with that. So that people can actually have the many ways in which they actually navigate their sexuality. Now, one of the things that intersex people in particular use in terms of language is that they actually refer to not using the terms like biological sex, but use instead sex traits, right? Because usually biological sex is already associated or create this kind of narrow-minded in ways in which how do we put people in categories of either male or female. And one of the things that intersex people is asking us is to look, either the sex that I'm born with can have actually different manifestations based on the traits that I engage with, either in terms of reproductive organs, either in ways of genitalia, or either in ways of chromosomes. So another way that they ask us is to avoid the language of born with ambiguous gender, ambiguous genitalia, right? And it's about born with genitalia outside of the typical male-female binary. So I will share these resources with you so that you can actually use, instead of using actually female male chromosomes, to use the XXXY chromosomes. And instead of female or male genitalia, it's actually to use vagina or penis, right? In a way that you need to be talking about someone's genitalia in the first place, if you really need to talk about it. So even myself that I identify myself as cisgender male gay, I have to challenge myself. This is a slide that I used to use, just to remind people that sex is biology, while gender is a social construct, it is a social context. And I myself have to come to learn as I continue my journey that sex is a trait, right, that people can have, and we can start talking about it in those terms so that we are more inclusive of the intersex people. Now, one of the things is that while that's a group that is even a minority within the sexual minority, I think that around 0.3% of the people identify actually as intersex within the country, here in the context of the US. So based on that, I would like to we have actually 44 people participating today here. And I want for us to create a breakout room in which we want to answer these questions that you have here. So how would you describe your gender identity? How do you show your gender identity to others people based on the way you look or act? And has that gender identity or expression changed over time? Thinking about the time in which, even when you were a kid, the way that you dress, the way you want to actually play with things or express yourself, had that changed over time? And then if it has changed, how? And how people reacted when you start changing, when they start noticing, and what messages do you hear? I will put these questions again, and we want to do dias, okay? Only 2 people per breakout room. So that means that we do 44, that's 22 breakout rooms that we would like to create. And Cindy, if you can help me with that, would be really good. And it will be randomly. And of course, you share what you feel comfortable sharing. But I want us to create this idea of how even my gender identity, it has changed or not over time. And if it hasn't changed, what it is the message that I've been receiving about how do I need to express myself in terms of my gender. So we will have 5 minutes. Each person will have at least 2 minutes to share. And I will paste the questions on the chat so that people can have opportunity to read about the question.
Okay, but mine has been pretty stable too.
Okay, they're coming back little by little. Sorry for the confusion in terms of what you were doing on the breakout room. I thought that when I copy and paste the question on the chat, everyone could have seen it on the chat, but it seems like it needed to be sent through a broadcast. But hopefully you have a chance to share at least for a few minutes about a little bit of the history of how your gender identity and gender expression has changed. And this is also for us to familiarize with those 2 concepts, right? One is how I identify myself as a, that's my male or female or gender queer or gender fluid. And also how that actually has changed throughout my time when I was a kid or when I was, So, and I want us to stop sharing right now. I will stop sharing. And I want to hear from you. What was the experience for you? What did you notice? So what it came up as a result of, and if we can stop recording, Cindy, right now would be helpful so that people don't have to, and they're part of this. And they're part of the civic life of Mexico, particularly of that region. And they don't identify themselves as male or female, but as a third gender. The same in India with the Hiras, right? This is another group that, and they're actually a festival in India that is every year. And they all come for different parts of different regions of India. And they identify them as a third gender or a two-spirit. And this is part of the Native American culture, in with a person who is two-spirit, it could actually represent both male femininity as well as masculinity. And they actually show it within their labor or within the activities or tasks that they have within the family. So it could be a female sex traits identified, but at the same time, most of her activities and roles were actually hunting or bringing the food or harvesting, etc. Right? That were usually very male oriented. So, I mean, part of what it is for us is like to understand how all of these ways in which gender can be manifest and expressed, and particularly in terms of identity, is very important for us to understand it and start engaging with this gender fluidity and understanding more of the spectrum so that we don't actually sometimes be people in boxes, right? And again, one of the things is that even within the field of mental health, homosexuality actually is being, it was established for a long time as an illness, right? And it was actually on the DSM-3 at the time, as part of something that we needed to fix, something that it needed to be cured. And it was actually a mental health disease, particularly for psychology and all the mental and psychiatry. So we have that history. And also part of what it is important is that, you know, that understanding and that kind of discrimination, and even from the clinical perspective, it really created a lot of damage within the community in a way that it was prosecuted, in a way that were constantly attacked. And this is why this month, and probably most of you know this, right? But June 28th of 1968, it was the time in which at Stonewall in New York, particularly Cesar Rivera and Marsha Johnson were the one, and this is our, you know, trans people of color who really fought. And the attack of the police, in particular in New York City, at the Stonewall bar, right? And this is a historical bar. And if you've been in New York, you live in New York, if you have the opportunity to go right there on the Christopher area street of New York City. And it was a ways in which it generated the whole gay liberation front and a civil rights movement for people to engage on that, to engage in that liberation front, to fight for the rights of the LGBT people. And one of the things that homosexuality as a mental health disease is very new, right? It was actually in 1973, a little bit more years now, right? And one of the things was that there was 0 years of research behind that. And then you wonder how, you know, even within our field, how sometimes this continue establishing ways in which we can have biases toward the LGBTQ community. And even though we have still on the DSM-5, the description for gender dysphoria, one of the things that it is important for us to recognize, and we'll talk more about that next week, is how when people identify as non-binary, gender fluid, particularly depending on their age, that diagnosis can apply. But we have seen how sometimes puberty can actually change that. And we have seen actually like gender affirming therapy can also do that, can change that. So we need to start engaging in how do we grow in recognizing that these identities are also evolving so that we don't actually put people in boxes. So, and thinking about putting people in boxes, I want all of us to participate in this activity that I want to do right now. And what happens when somebody who doesn't act like a man, what kind of adjective do we use to describe them? Or we have used or we have here to describe when a person doesn't act like a man, or a person doesn't act like a woman or like a lady. So what I want to do right now is to, yes, Cindy just shared with all of you a Jamboard in the chat that you can actually use. And let me just tell you exactly how we are going to use it. Let me look for my Jamboard. Let me stop sharing so that I can look for my Jamboard. And I will share with you. Why I don't see my Jamboard? Oh, right here, yes, there you go. So this is what we want to do. You will have access to your Jamboard in your computer, and you can go right here, a sticky note, and you want to share, for example, what kind of words you hear or you have here, you know, with people when a woman doesn't act like a woman. So I can say a dyke and save it, right? And then I will put it towards acting like a woman. And if a person doesn't act like a man, then I will actually say CC or faggot, save it, and then just put it on the men. So let's take a few more minutes, and each one of you can actually name as many as you remember, and do this, and we can all see it. How people name, particularly within those two genders, when somebody doesn't act like a man or doesn't act like a woman. Bucci, you can move it yourself. I start moving, it's all right. Thank you. Anybody? Yes, thank you. Mhm. All right. Anybody else? I hope that each person let me put one that I actually hear. Okay, so we can continue playing with that. And I'm just going to read some of the ones, and you can read it yourself. But I want to ask people, what do you think, what do you notice in this name calling, if you want, right? What do you notice just by looking at the labels that we put here, that we see? I never heard this one, sugar in the tank. That's a new one. I never heard that one. What do you notice? You can unmute yourself and share with the group. One of the things that I noticed is that there is more kind of the blue color associated with the men and the pink color associated with the women. And that was probably my fault because I started that. But again, that's some of the associations that we have usually, right? In terms of even when we are born and how do we buy clothes when it's a baby, what colors do we pick, right? For that. So the other thing that I noticed, and you can put your comments also on the chat if you're more comfortable doing so, is most can be seen as degrading. Exactly. So most of these labels actually in a way are degrading to the person, because part of what they're doing, they're trying to make people to conform to what the dominant culture is, which is very binary ways of how you should behave, dress, express if you're a woman, and how do you express, behave, and be as you're a man. And another thing, if you notice here, is that if you see the one on the men, that's what we call sexism, right? How sexism is very connected also to this. This is girly, pussy, furry, sissy, fruity, right? That can be ways in which how we womanize men if we want them to feel bad about themselves, just because of the way that they express themselves. So that, remember, your manhood means something different. And you need to behave accordingly. You need to express accordingly. And anything that you do that is womanized, then we use it as a weapon towards you because you're not being man enough. So again, we need to pay attention to this because this is in a way in which how we actually utilize gender in order to constrain and to limit people for who they are and put them in boxes. And, this process of how we do this, and thank you everyone for taking the time to do so, that this is part of how stigmatization and discrimination of the LGBTQ community happens in a way that somehow create this homophobia towards people in the way that they express and the way that they are. And one of the ways that when these identities get intersected with the ways in which all of these aspects of what we thought last week about the economic justice, the transportation justice, healthcare, immigration, community infrastructure, reproductive justice, when all of that intersect with the person's identities, it really creates the ways in which all those isms that we talked last week are enacted, right? Sexism, homophobia, heterosexism. And this brings us to this idea of how these ways in which this impact health inequities in people, particularly the LGBT community. And I like this concept that was actually first introduced by Margaret Whitehead, in which she defines health inequity as the difference in health in which are not only unnecessary and avoidable, but in addition are considered unfair and unjust. And so what it's telling us is, in a way, these disparities or these inequities, they are necessary, they could be avoidable. They could be actually what we call the social determinants of health. If you see at this right here, only 20% of the human interaction of the human being really interact with the healthcare system impacts the ways how people are healthy or are becoming healthy. So 40% of them are socioeconomic factors that include education, job, family support, income, community safety. 10% is physical environment, housing and living conditions, and then 30% is health behavior. And those are the ones that we actually work on, in terms of how do we prevent for people to become healthier. But as we see here, part of the sex trace of biology and science of the healthcare system is only a very small part of how people become healthy. And again, how do we address that so that people become more healthier and more equitable community in which people actually and individuals and families can live, learn, work, and play? So this concept of health equity is very important for us if we want to see at these social determinants of health, particularly for the LGBTQ community, because health equity means that everyone has a fair and just opportunity to be as healthy as possible. Of course, this is not going to happen unless we actually intentionally moving those obstacles so that people can access health in ways that poverty is addressed, discrimination is addressed, and their consequences. Now, let me just share with you some of the health disparities that the LGBTQ community confront as a result of these structural inequities that we see in society. And because of the traditional ways in which, how do we see sexual orientation in a way that has trying to become heteronormative, and the moment that is not behave that way, then we start seeing the structural inequity just coming against LGBT, lesbian, gay, bisexual, transgender people. So in general, one of the ways, particularly working with the youth population, is the unhealthy impact that bullying has in youth. And there's many ways in which actually particular students, that 71.3% somehow hear homophobic remarks, like the one that we were just working on, dyke, faggot, in a way that is often very frequent. And that made to feel them very unsafe. In fact, there is it used to be the Gay Straight Alliance Network. It's called now the Gender and Gender Equity Network. That they actually did many studies in high schools. And one of the things why students don't go back to class and there is a lot of absence is because of that bullying. Now, 8 out of 10 students have been verbally harassed and 4 of 10 have been physically harassed at school. And we know that sexual minority youth are at increased risk of smoking, dating violence, and suicide attempts. In fact, we do know that compared to cisgender youth, transgender youth are 2 times more likely to have depression, anxiety, self-harming behavior, and suicidal thoughts and behavior. Now, what other aspects that the LGBTQ community really confront is actually substance use. And if you see in this graph, across almost all the substances, right, either illicit drug or alcohol, or only alcohol use, or illicit drug use, marijuana, or even pain reliever, the sexual minority community usually has a higher percentage of use compared to their sexual majority counterpart. And this is also represented also among homeless youth, in which they have a higher use of alcohol than heterosexual counterpart. Now, homelessness is something that is very important for us to consider because the homeless youth population 40% of the homeless youth population identify as either lesbian, gay, bisexual, or transgender, compared to the general youth population who are homeless, which is only 7%. And this is very important because part of what studies have shown is that particularly among the LGBTQ homeless populations, they experience poorer mental health, either depressions, higher depression systems, higher PTSD symptoms, higher anxiety and aggression. And these experiences really impact the well-being of homeless youth. And it is because it also impacts homeless and suicidality, right? We know that LGBTQ youth are 9 to 10% points higher than those of non-LGBTQ homeless youth to actually have suicidal thoughts. And LGBTQ are 6 to 7 times more likely to attempt suicide in comparison with the heterosexual counterpart. So suicidality and suicidal thought and suicidal attempts are very high among homeless LGBTQ youth and LGBTQ youth in general. We also know that LGBTQ individuals are 1.5 times higher risk of depression and anxiety disorders than heterosexual individuals. And we see this in way, and we will talk more about next week, about the ways in which how these are manifested in terms of their behavior, in terms of the suicide, and the correlation that exists between these conditions and suicidal attempts, particularly among transgender youth. We also know that in terms of transgender and gender non-conforming people, they do have a very high percentage of attempt of suicide, compared, right, with 1.6% of all people in terms of the population. And if we actually do this in terms of the Latinx community, this 41% goes to 47%. Of Latinx and Hispanic transgender people reported having attempted suicide compared to the 1.6% of the general population. Another way is that particularly among transgender, not only the 41 have attempted suicide, but they actually feel very uncomfortable with seeking help from the police, and they have 90% of them have actually experienced discrimination at work. Now, Latinx and Hispanic transgender people have experienced far higher rates of discrimination than the general population. And one of the things is that 20% of Latinx Hispanic transgender people reporting being refused medical care due to biases. And 36% have reported postponed care when they actually were sick or injured due to fear of discrimination. Now, smoking is another aspect that we sometimes don't talk about the LGBTQ community here. And one of the things that there is a whole campaign to look at how we can make smoking an issue, particularly because the impact that it has in people's life years lost. For example, smokers with HIV, they have lost up to 12.3 years compared to 5.1 years of non-smoking with HIV. In compared to the general population, as you see in the middle, 33% of the LGBT population actually have higher rate of smoking compared to 20% of the US population. And one of the things in terms of policy that you can see in that on the top of this graph is not only until only three Surgeon Generals within the different administrations have actually named the issue of LGBTQ and smoking and the implication that it has for cancer. And if we actually look at particular US adult smoking rates, if you see again, not only that the LGBT community, but the transgender smokers is higher than even the LGBTQ community or straight smokers. Another aspect that is important and probably many of you are familiar with is the LGBT community and HIV. We do know that the LGBT sexual minority are definitely impacted by HIV at a rate that is compared with their heterosexual counterparts. But one of the things that it is important here is to see the number of new infections, particularly among youth of color, which is actually have increased tremendously. And one of the things is that many young gay and bisexual men are unaware of their HIV infection. One in every 4 are actually not tested. And so one of the things that it is important for us is how we engage particularly young Latino and Black and brown men to engage in their own health. But one of the things that the CDC studies have shown is that gay and bisexual men, particularly ages 13 to 24, made up most of the new HIV diagnosis among all gay and bisexual men. So it is important for us to recognize this when we want to work with this community. And one of the things that this community studies have shown is that they usually have different fears to come to seek for help. One is they're either afraid to go to the clinic because they have to disclose their sexual orientation, and they're very afraid of being actually gay. They actually sometimes don't have access to condoms and lubricants, even though that has changed, but it's still. And also the fear and the stigma associated with HIV that it has created in many ways fear for particular people of color to access testing and treatment. Another topic that we don't talk much about it is actually anal cancer. And we have seen that anal cancer particularly is 34 times more prevalent among men who have sex with men. And sometimes we don't even talk about this in terms of sexual health. And there is a lot of taboo in which when we engage with that. And I think that for us as a clinician, one of the things that I always thought about what happened when clients come to us in therapy and they start talking about their sexual life. And if we haven't felt comfortable even talking about our own sexual life, how we want to engage that with our clients. And this is, we will talk more about that next week, what kind of skills and techniques we can use. But again, if we're not comfortable talking about sexual life and sex in general, how we want to talk with our clients. I think that we do know that NL-HPV-16 infection is significantly more common in men who have sex with men, especially those living with HIV. And it has an impact in how cancers develops in these patients. Either within the LGBTQ community, one of the things that I want to actually stress here is the impact and the disparities even within the LGBTQ or the bisexual community. And this community actually faces extreme health disparities, higher rate of tobacco use, compared even with heterosexuals and gays. We're talking about smoking, it is still higher within the bisexual community. Higher rate of anxiety and mood disorder compared again with heterosexual lesbians and gays. Was bisexual women are the most likely to have or never have a cancer screening, a mammogram or pap test compared to heterosexuals and lesbians. And bisexual women have more risk of factors for heart disease compared to heterosexuals and lesbians. And actually, it's not here, but it's also obesity is higher also amongst the bisexual community. And one of the things that happened in terms of how this impacts the health disparity is in this study report by Michael Johnson and Lynn Demand, they say that bisexual men and bisexual women, they do not disclose their sexual orientation to any medical provider. In fact, compared with gay men and lesbians, the percentage of reporting their sexual orientation is lower than bisexual people. So there is a lot of stigmatization, particularly about bisexual folks, in a way that even within the LGBT community, because it seems like they're either confused in terms of the sexual orientation, or they're not clear, and because there is so much stigma about it, they prefer not to share. Another thing that it is important is kind of the laws within the US. And if you can notice here, all the anti-bullying LGBT laws are either on the east side of the country or the west side of the country, right? But when we see the South, we can see how it's still restrictive laws, particularly for the LGBT community. And you know, I'm in Texas, and one of the things that we have worked for so many years is, for example, employment discrimination. You still, now because of the federal law, I can, and it was passed recently, but I can still could be fired out of Texas if somebody disagree with my sexual orientation, and there is no consequences for it. So crime against the LGBTQ community is also important to resolve here. If we can see the biases, motivation for crime, if you see, of course, race and ethnicity is the highest, but then after religion, we have sexual orientation. And if we can see, you know, hate crimes motivated by sexual orientation, almost 60% is anti-male homosexual. So all of this crime and violence against the LGBT community, we have seen it in many instances, particularly trans violence. If we see trans violence, we see that 91% of them were actually Black women. 81% were under the age of 30, and 68% live in the South. We actually have the highest number of murders of trans people last year, to 45, according to HRC. And even this year already, we are about 26, and in Texas, we are about 9. So this is really something that violence against the LGBT community is very important, and hate violence in particular. There is 53% of anti-LGBTQ homicides were transgender women, and 73% of those were victims people of color. And if we notice about the motivation of hate crime, after anti-immigrant feelings or anti-Black feelings is anti-LGBT. So imagine if you are a Black trans immigrant woman. And what is the impact that they can have in your life, right? Thinking about intersectionality. So sexual violence is also very present in the LGBT community, particularly in the bisexual community. If you see here, the victimization rate among heterosexual women and lesbian women is kind of similar. It's still, however, when you see bisexual women, you see that this is substantially higher, at 46%. And this is for substance facilitated rape in their lifetime. Sexual assault also, again, is higher for bisexual women, almost 74.9%, in comparison to 43 and 46% of lesbian and heterosexual women. And even though there is not much data, particularly about sexual violence in men, particularly because of reporting, but coerced rape and sexual assault and no contact of wanted sexual experiences by gay men and bisexual men, which is again even higher, is almost double when we compare that to heterosexual men. And we just have 5 years anniversary of Orlando, right? In which one person decided to kill almost 50 people. And it's actually the larger number of people that have been, I don't remember if compared with the one in Las Vegas, but it's one of the largest number of people that has been killed. And, but this is very specific towards the LGBTQ community. One of the things that continues also to happen, and I know that it was actually finally not allowed, particularly for clinicians to use recovery therapy, particularly for the LGBT community, because of the damage that it has created. But it's still some clinicians thought that they can actually cure being gay or being lesbian, right? I think that one of the important aspects that we want to also resolve here is that compared with people who are heterosexual, people who are lesbian, gay, or bisexual have higher rates of health conditions associated with serious COVID illness. So this is also important, like asthma, chronic obstructive pulmonary disease, stroke, kidney, cancer, and heart disease. So these are actually disparities that are associated with the LGBTQ community that we need to take in consideration with COVID. So but this picture is not all bad, right? And this is when we actually come in. It is believed that when Jews who actually can have a happy LGBT adulthood life, if their level of family acceptance is extremely high. So, so they can actually, family support and accepting for youth, it will have an impact increasingly, particularly when they become an adult. If you see here, the less accepting, the less foreseeing future that they can actually see. And this is important as a protective factor, particularly for suicidal ideation and suicidal attempt in youth. There is the It Gets Better project, and I would really recommend to visit itgetsbetterproject.org, in which you can find a lot of resources, particularly with youth, to provide resources for them. One of the things that the transgender patients care guidelines have been created for transgender affirming hospital policies, and also the stigma project, kind of like Live HIV neutral. One of the things that that I want to share with you is that sometimes it's being hard, particularly for Jews, to come across all the different ways of how they want to be in reference of their gender identity, of genders, sexual orientation, and how the many ways in which harassment, transphobia, rejection, trauma, anxiety, they all intersect in the work of this community. And the ways in these health disparities have been presented, it really creates a complex picture, but it also a picture that it is, and if you include actually race in these conditions, it really impacts even more the sense in how these people can actually engage in healthy behaviors. So how we can then create a more inclusive care for the LGBT community. I wanna actually stop sharing and give at least a few minutes for us. If there is any question that you have, any thought that you wanna share with the group about how we can address these disparities and what kind of question do you have if you haven't worked with the LGBT community that you can engage with. I know that we only have 4 or 5 minutes left, but I want to give time for people to have some questions and thoughts about this. Anybody? And go ahead. I don't know if Jacqueline or Jovanska were trying to talk, or you were just on mute.
Hi, this is Faye, and I was, you know, when we had the exercise to identify some of the what I call derogatory language against LGBTQ. I don't know if I got it all right, but I didn't participate in that because the language was so strong for me. I'm like, oh, I don't use that language. I'm a female person, heterosexual, and I took offense to the language. I know people who are trans, and I see them as individuals, and it was hard for me to process the language of knowing, well, putting a face to that. I like, they call my friends that, oh my gosh. And so that was very, very unsettling for me to do that. And I didn't do it for that reason, because it's not like I don't have a face to, let me just make sure I got it, say it right. A face to someone who's LGBTQ. I have a face to it. And so that is a family member, it's a colleague at work, It's
Yes.
a friend I went to college with, and they were afraid to tell me. And I said, you know, we're different, but I respect who you are, and
Mhm,
we're
mhm.
still friends. And I just really became offended by the language,
Mhm.
because I
Yes,
looked at it in
yes,
terms of, I looked at it in terms of people that I know.
yes, definitely, definitely.
And
And
so
thank you.
I just would not want
Mhm,
anybody to
mhm.
treat anyone that way. It was very discriminatory,
Yes,
and it was very
yes.
hate, I call it hateful.
Hateful.
And
Yes.
even if
Mhm.
I didn't know the person, I would
Yes,
still feel that way, because people are
yes,
people. But
yes,
especially
yes.
because I know of people,
Mhm.
and I had a family member who passed away, and a lot of people um, attended the service, and I said, okay, these are this person's friends, deal with
Mhm.
it. And so
Mhm.
it
Mhm.
didn't take the love away that I had for my
Yes,
relative. I
definitely.
still consider that person as my relative, and
Yes.
always will, even in memory. But I,
Mhm.
like I said, it was very unsettling to think that those
Yes.
names would be
Yeah.
ascribed to people that I
Mhm.
know and that I
Mhm.
care about.
Yes.
And that was
Thank you,
that's all.
Faye. Thank you, Faye. Thank you. Because I think, and I do the exercise on purpose. I mean, I myself gay, right? And I have to deal with any of those ways in which societal have really used those terms to discriminate against, to put us down, and to really control even our own gender. And they are offensive. And I say that actually, thank you when we finish, because it is also really brave for people to put them there, because they're hurtful and that's their purpose, right? And I think that, thank you for sharing that, because in a way, like, yes, they are offensive, but I think that I took the liberty to take, and I hope that anybody who identify in this group as as gay, lesbian, bisexual, and we do have some people in the group who identify as such, that, and that's what I said at the beginning, we want to use language that could be harsh, but what I want us to take in with really the perspective of how it is that we as practitioners can actually understand how other people feel when they've been calling like that, or they've been dealing with those terms for years, right? And we hear sometimes when clients come to us, like the ways that they actually feel very minimal, just because of all those name callings have, and the bullying, it have impacted them. And that's what I use it here, with a way of us to see this could be very impactful for the people who actually see themselves or have received this for so many years, right? And what is the work that we need to do to heal them, to support them? Because those terms are real out there. And people have been hearing them since a very, very young age, and how much pain is associated with that. So thank you for that comment, Faye. I really appreciate it. Anybody else before we go? Any thought, any comment? I know that Jacqueline say, thanks for sharing those feelings, and thank you for this exercise to really humanize people. Anybody else? I think Cindy's put in this survey. And Cindy, if you can also share the answer key to the quiz that we put at the beginning, will be helpful as well, so that people can look at the answers after you do it. And so in a way that we can actually learn a little bit more about the terminology and the language, to be more familiar with that, which will be very important for our own clinical practice.
I did share those like 10 minutes ago. I'll just upload it again in case somebody missed those.
Oh, okay. You share both. Oh, I seen it here, yes. So you can download it, the answer key for the quiz. Any thought that you have? regarding, and I know that the health disparities this is a rough presentation and difficult, because one of the things that I want all of us to take here is that while those disparities are real, people have a lot of resilience. And how do we approach? So I don't want this information to really continue stigmatizing this group. I think that what it is this is a part of the real part of it, right? This is the reality that these people actually confront, and how it is that we can do as helping professionals to support them so that they empower and we somehow eliminate the health disparities that exist. And I know that those sometimes are structural, but when it comes for us to the mental health, how it is that we can actually support them.
Thank you. I think for me, something that was really helpful was to see how health is impacted and see that breakdown. That 40% has to do with these structures that aren't really being targeted in addressing these health disparities, but that we as for example, I'm about to graduate, so future mental health professional, can help in addressing some of those issues. And as somebody who switched careers from a medical field, that we can still contribute to helping to that, even just talking about difficult topics and asking these difficult questions, but that also requires us to be able to sit with that discomfort, which can be so difficult.
Yes.
To like talk about sex, to talk about these things that they're hearing, awful dehumanizing pieces that are happening in every sphere of their lives.
Yes.
Our lives.
Definitely. Thank you, Jacqueline. Thank you. I skip a slide purposely in the presentation. And I know that if people need to go, you can go. I'm willing to stay a little longer. Happy to stay a little longer, actually. But I skip, I used to be the executive director of a LGBTQ organization, working with youth ages 12 to 19. And 19 because we did have a lot of foster kid, and but after 19, after they out of the foster care, and because of legal reasons, and we can talk more about next week about what we did. But let me share with you quickly a letter of a kid that it was a trans kid, and he was transitioning from male to female. And he wrote this letter to us. And I want you, if you have time, just take a second to read it. So, and you will have it in the presentation. This was a 13-year-old kid. He had actually finally get his father to agree to go with him to the mall to buy girl clothes. And after that Sunday, she was in therapy with one of our clinicians, and we received on Monday when she went to school, after leaving school, 2 kids got into the tree and wait until she finally was dressing as a girl to school because her father finally admitted to it. And we did work with the parents and, with the school and all of that, but took his way for her and pee on her when she passed by. And that day she wrote that letter and she took her life. And she, you know, her parents share it with us. And I usually sometimes in presentations, depending, but I want to share it with you to see as, you know, just the pain that how people go through as a result of this language, as a result of these labels, as a result of these constant ways in which to put them down because they're different, you know? And it was hard, and this is something for us to take in consideration, and we will talk more about next week, that, you know, this is a high-risk population in terms of suicide, and sometimes that's what happens. And we need to be prepared how we want to deal with that, right? Because as much work as we can have done with the client, it still can happen. Thank you for those of you who could stay to share that. And if you have any thought, please feel free to share. And if not, we can consider ending here then. And thank you again for coming. Thank you for staying a little longer. And we will see each other next week just to talk about what kind of interventions. And I think what Jacqueline was saying, Jacqueline Restrepo was saying, is because it made me think about it, because after that, we decided that we needed to do something, not just on the clinical aspect of the individual, but in the schools. And we created a program, and we'll share more about that next week, that it was how do we work with the schools to prevent the bullying for that. Okay, thank you everyone. Thank you again. I really appreciate the opportunity and the space to be here, and we will see you next week.
Thank you very much.
Thank you.
Yeah, thank you, everybody else. We'll see you on the 25th for interventions for working with LGBTQ plus population. And if anybody couldn't download any of the files, just write us an email and we'll help you with that. And with that said, I think we're ready to go. So thank you, everybody. Thank you, Ortega, for a great presentation. I hope everybody enjoyed it.
Thank you.